Hi, good morning, everyone. My name is Txplnt, and today I'll be presenting to you about red blood cell alloimmunization, which is a risk factor for liver transplant outcomes. And is it a risk factor for liver transplant outcomes? I don't have any disclosures. Maybe one day I will get some, and all images have been made with biorender. This is the outline that I'll be talking about. We'll talk about a little bit about me, and then we'll move on to the red blood cell alloimmunization and liver transplantation. We'll start off, we'll launch with a case, talk about some recent transplant data in the United States, talk about what red cell alloimmunization is, and a bit of the basic science behind it, but very briefly. We'll discuss transfusion support and solid organ transplantation, and we'll focus mostly on liver transplants. And then the research that was done in this space by others, myself, and future studies that are potentially going to be done in this space, possibly. So a little bit about me. I was born in Vinnytsia, Ukraine. My family then moved to Toronto, where I completed some of my education, like undergrad and grad school. Then I completed my medical school in the gorgeous Lexington, Kentucky, with horses and bluegrass. It was beautiful. The medical school experience there was absolutely lovely. And then completed my residency in Northwestern in Chicago, Illinois. And currently I am in Boston with a big question mark, because the question is where I will be going next after I finish fellowship. And I would love to, to go to another great place to continue my training, and so on and so on. But that's the question. That's what the question mark is here. So a little bit about me. This is our family. That's me, Wenyu, my wife, our kiddo, Julian, and he is super cute. He is a handful, but it's a fun handful, and he's 1 year old, so he is just learning how to get into more trouble. So he keeps us having a good time. And let's start on the topic. So why should you care about red cell alloimmunization in transplantation, especially liver transplantation? And my goal is to, hopefully by the end of this presentation, maybe to not fully convince you why you should care, but at least start the conversation. So let's talk about a case. It's a 64, and by the way, I made up these cases, the HIPAA-free, the HIPAA-safe. It's a 64-year-old male with liver cirrhosis secondary to metabolic-associated steatohepatitis and chronic kidney disease. They're scheduled to undergo a simultaneous liver kidney transplant. They're B positive. Their antibody screen has an anti-K phenotype of the red cells is negative for the K antigen. And then the next step, is this difficult blood to obtain? No, it's not. 90% of random blood donors are K antigen negative. So we follow the standard SOPs, and this is institution dependent, but at Beth Israel Deaconess Medical Center, we will allocate 10 red cells. We'll cross-match 10 red cells to this case, and then after the second cooler goes out, or when they use approximately 10 red cell units, we'll have a conversation with the clinical team if and when they want more, to see next options and the next possible direction. And we can use our hospital inventory, which is key because, again, 90% of random blood donors are K negative. Let's switch this up just a little bit. It's the same patient, but now this patient has an anti-big K antibody, an anti-JKA, and anti-little c. Red cell phenotype are negative for these antigens. And is this a difficult blood to receive for this patient and to provide for the surgery? Yes, it is, because less than 5% of random blood donors are going to be negative for these three antigens. So here's the challenging situation. It's not that challenging. It's just hopefully we know about this surgical surgical event early, so that we can call our American Red Cross blood supplier, which we love. They're very, very good, and maybe order 20 units. Because the thinking here is the liver transplant surgeons are very, very good, And as I will talk about this a little in the next few slides, we're anticipating about 10 red cell unit or less used per liver transplant case at this time in current practice. But that is not for sure. Surgical complications or patients' cases can be challenging, and we need to anticipate that if there could be any sort of complications for any sort of reasons, that blood has available so that the surgical team has the blood and the patient has a good outcome and is supported throughout the surgery with our blood products. And maybe we will get 20 just to be safe. And the units that we don't use, we can release them to other patients in the inventory. So it works quite well. Let's talk about the national transplant data. How many patients are currently waiting for transplant? It's about over 100,000. There are 20,000 donors per year and available per year. And majority of transplants performed annually, it's about 40,000. 10,000 of those are liver. The remainder are kidney. Kidney is the number one transplanted organ. And the median red blood product per use for liver transplant historic, it's 35 units per liver approximately in the 80s. Modern, we're looking at 5 to 8 units per liver transplant case. The rate of red blood cell alloimmunizations in liver transplantation, well, in liver transplant patients, it's 4 to 9% because they do get more transfusions, and they're generally complicated patients with complex medical histories, and the general population, it's the red blood cell alloimmunization rate is 1 to 3. And the question again is red blood cell alloimmunization in liver transplant recipients associated with worse outcomes? And this data is gathered from OPTN from 2024. Again, to reiterate on similar fact, there are over 100,000 waiting list candidates for transplants. Majority of them are for waiting for a kidney, but a large portion of these patients are also waiting for liver transplants. These four graphs here is just to reiterate that the demand and the need for solid organ transplantation continues to increase from year to year, and the demand continues to grow. There is not enough donors, and we would love for there to be more donors for solid organ transplants. That is a different topic for a different presentation. The estimated rate of transfusion reactions, this is important to touch upon this because why do we care about red blood cell alloimmunizations? Is because they can lead to transfusion reactions, specifically specifically delayed hemolytic transfusion reactions, but it's nice to also mention acute hemolytic too. So let's talk about delayed hemolytic because they're more relevant to this talk. The incidence of delayed hemolytic transfusion reaction depends on the population being looked at. If we look at all of the American Red Cross compendium data from 2021, and that captures the national data, it's approximately one reaction per 50,000 patients, but this is different when we consider specific patient populations. For example, sickle cell disease patients have complex transfusion requirements, especially in chronically transfused sickle cell disease patients. They tend to form more allo antibodies. So the rate there is higher. We're looking at 1 in 50 cases. Transfusion News estimates the incidence of transfused delayed hemolytic transfusion reactions to be 1 in 2,500. On the boards, the boards they feel the correct answer is 1 in 5,000, and but again, on the lower end, national data taking it all together, it's 1 in 50,000. So again, these are the next numbers are just approximates. This was from a few years ago, so these are not current numbers. But at Beth Israel Deaconess Medical Center, they approximately transfuse 20 to 30,000 blood products per year. Northwestern Memorial Hospital, where I completed my residency, they transfuse approximately 50 to 60,000 blood products a year. So if we take those numbers, we look at the general, we can just focus on the general approximate expected incidence of delayed hemolytic transfusion reactions. We're looking at 8 to 12 reactions at Beth Israel Deaconess Medical Center per year. At Northwestern, the number is a little bit higher, 20 to 24. And this is the same type of thoughts that we need to have in the background when we are transfusing units into liver transplant recipients and other situations, because delayed hemolytic transfusion reactions, we want to avoid them when we can. A little bit about red blood cell alloimmunization, and this is a very complex topic, and there's a lot of active investigation in this field, but the high yield point for this talk is that red blood cell is covered with many protein and sugar antigens, and some of them can be less or more immunogenic. And not everybody forms antibodies against these antigens, but at this time, there's over 400 blood groups, and there is a number of antigens which are still being discovered, and some of them are more immunogenic than others. There's a picture of the more higher yield antigens to which patients are more immunogenic, like RH and KEL, and which we will see pop up in this presentation. And again, there are patients who respond to these antigens and form antibodies, and there's patients who do not make alloantibodies. And again, a very interesting and lovely area of investigation. Happy to talk about this later when needed. So let's talk about, so we covered these areas. Let's talk about transfusion support for solid organ transplantation. The story starts here. In 2022, Dr. Ramsey, my mentor, he published a paper talking about blood banking and solid organ transplantation, and he described that there are approximately 150,000 organ transplants that are performed annually worldwide, and transfusion support is critical for every one of these patients. The liver transplant posed the greatest challenge. There are more and increased rates of preoperative red blood cell alloimmunization, because again, these patients are complex. They have a lot of medical underlying comorbidities, and it's quite likely they have been transfused prior to their transplant. And even and then again, it is known that higher blood product use is associated with adverse outcomes. Once again, the mean red blood cell unit use at the moment per liver transplant, and this is approximately expected, is 4 to 9 red blood cell units per case. Here is a table from the paper demonstrating the transfusions in adult liver transplant programs. You could see from historic reasons for Pittsburgh in 1981, approximately 36 units were used for liver transplants at that time. Through increased education, transfusion guidelines, intraoperative red blood cell salvage, visco elastometric testing, and surgical techniques, better technology, and surgical skills, this number has been reduced to 5 to 10 red blood cell units per case, and at the moment. Frequency of red cell alloantibodies in liver transplant, again, it depends on what study you look at, and some of these studies, they examine the pre-alloimmunization rates and the post-alloimmunization rates, and you could see there's 10 cohorts here over 30 plus years. The preoperative median rate was 6.2, and the total overall median rate was 7.4. And depending on the cohort you look at, some patients develop alloantibodies post-transplant. And again, to reiterate, in the general populations, it's 1 to 3% of patients have alloantibodies, and in most series for liver transplantation, it's 4 to 9, so a little bit higher. Let's talk about the research in this space. So at this time, the paper that started this question is that an article was published in 2007 that showed that alloimmunization to red blood cell antigens affect clinical outcomes in liver transplant. Talking to Dr. Ramsey, we thought, hey, this is a great topic. We could potentially do a retrospective case series, and examine this in more detail. But before we decided to do that, let's talk about this paper. And it is a good paper for 2007, and the authors looked at some high yield topics that are very interesting. For example, this is a retrospective study. It had 2009 liver transplant cases. 20 of them were contained red blood cell antibodies. They found statistically significant variables for poor patient survival were number of red blood cell and plasma units transfused, history of red blood cell alloantibodies, and immunosuppressive regimen use, as well as pregnancy history. Some of this is not surprising, but it is great that they published on this because it helped us start the story and move this project forward. You could see from their table 1, this is their cohort. Their median age of the patients in the study was 50 years old. And you could see there's some of them, 20% had a history of pregnancy, and 10% of them had an antibody formation history. They used a median of 8 red cell units, but sometimes they went up to 18. And you could see that they also talked about the immunosuppressive regimen that they used. For example, 1 and 2, 1 was just tacro, 2 was tacro and prednisone, and 3 is when they combined multiple immunosuppressive drugs. They used a Cox hazard model for mortality after liver transplant, and they found that history of pregnancy was significant, but barely significant, but it was still significant in their cohort. Alloantibody formation history was significant for mortality, and red blood cell units was the significant. If they, it sounds like if they got more, well, yes, and the immunosuppression method was significant. So patients who were immunosuppressed were more likely to have mortality. But also looking at this from a different perspective is one of the biases in the study is that patients who are sicker and who have higher immunosuppression, receive more red cell units, have history of alloantibody formation, are expected to possibly do less well than patients without those risk factors because they could be sicker patients. And so this is, while great, it's not super, it's expected in a way to find this information, and it's great that the authors showed that this is present because this is expected. Let's talk about this figure that shows that increased red cell transfusions are associated with reduced survival. Again, not expected. If a patient undergoes 20 or more units used during surgery, they are at risk of reduced survival. And they examined other factors like coagulopathy, higher MELD, but only increased number was associated with survival, and this was not due to coagulopathy or higher MELD. They also looked at, they also they put a disclosure in their discussion saying that it's possible that increased transfusion is a marker of some other clinical variable, but not directly assessed here, such as surgical technical difficulty affecting some of cases and not others. They listed in their table 3, and I really appreciated this, the antibodies that they found in the patients who were alloimmunized. They had 20 patients that were alloimmunized, and they found that those who have alloimmunization had worse outcomes, reduced survival after liver transplantation. And these are the usual suspects: Rh, JK, KID antibodies, and let's see, they had a few KELs as well. Again, expected suspects in this group, and they explained this saying that patients with red cell alloantibodies have increased proportion of cultures with 30 days of death versus those without. It's a good direction to explain this. They said that red blood cell antigen exposure can impair defense to microbes, possibly, but again, this is a retrospective study, so they're looking at us. They have associations, not causation. It's hard. That's all they have here. And they talked about how red blood cells can affect the innate immune system, and they talked about that. But again, this was a great direction for the discussion that they took it, but there could be more to the story that can be examined in further studies, and other studies currently are examining by other authors. So they had limitations. Unsurprisingly, they had a small cohort, but again, this is 2007, and maybe, possibly at this time, this is all they had. And that is still a respectful cohort for 2007. They also had a single institution study, and again, those are the limitations, and I respect those limitations because they're present in many other studies that we read and that are published all the time. And this is, again, retrospective study. They could look at associations only, no causation. They looked at red blood cell antibody presence, but they didn't mention any hemolytic transfusion reactions, which is something that is an outcome that can be measured or is usually reported and can be reported. They looked at confounding bias within the study. For example, pregnancy. It's unclear why patients with a history of pregnancy do poorly, but it could be that they have an HLA antigen source because pregnancy is a source of HLA antigens. Again, did not address this. And unsurprisingly, sicker patients did worse. If a patient gets more red blood cell transfusion, it could be a technically challenging case. Surgical complications, maybe the patient had some sort of transfusion needs post-surgery. Patients with red blood cell antibodies likely had, again, prior complex medical surgical history. So again, healthy people don't get transfusions and make antibodies. And immunosuppressive regimen is not surprising because patients in the third regimen were sicker patients, so they had poor outcomes. So were they just measuring the effect of disease severity in this study? And that is a possibility, and that is a challenging bias to address with this study. But respected them for publishing it. At Northwestern, when we saw the study, we realized that we were well positioned to look at this further, because if there's an association, and they saw it in a 200 case cohort, we wanted to see if there could be something else there that they're not seeing. Maybe this goes a little deeper, and we were well positioned to study this association. Northwestern has a very high transplant volume, and you could see that. This is from the OPTN public data. You could see that in 2023, just for instance, Northwestern performed 650 all-organ transplants. And when you look at the livers, you could see that in 2023, we transplanted 138 livers. So we do roughly, I think it's about 100 a year of liver transplants. So over 20 years, there's a sufficient volume for a retrospective study. This paper is the paper that we worked on, and that we worked on to address this question. We found again that alloimmunization against red blood cell antigens is not associated with decreased survival in liver transplant recipients. I worked on this with Dr. Alcino Perez Gama. He is fantastic, with mentors by Dr. Glenn Ramsey and Dr. Guan Yu Yang. The gap in knowledge that this paper filled is red cell antibodies are not associated with decreased survival. And we had 132 red blood cell antibodies detected. 3 of the most common were, again, anti-Big E, so RH, JKA, KID, and KEL. Red blood cell antibody prevalence was 6.5%, and the top 3 causes of death were infection and primary and recurrent malignancy. So I kind of gave away the whole paper, but let me walk you through it and convince you that this is what we saw and the next direction that we wanted to take. So this is our table 1 that talks about the 2 cohorts that we studied. We had a red cell antibody negative cohort and a red cell antibody positive. The negative cohort had roughly 1,300 patients, and the positive had 91 patients. You could see that the cohorts are similar. There's no difference between them for age, sex, follow-up, and survival. And you could see the median survival is quite great at almost 15 years for both, actually 15 years for both. So it's fantastic survival. We looked at the red blood cell alloantibody prevalence categorized by blood group and antigen. So we found 132 red blood cell antibodies, and the most common were to RH. 50% of our antibodies were to RH, big E making up almost 30%, KID making up 18%, JKA being the most common, MNS 11, big M being 6, and big Cal blood group almost 10%, with big K making up majority of those antibodies in that blood group. We proceeded to look at also multiple antibodies and patients with multiple antibodies. So we had 27 patients who had more than one red blood cell antibody. The common combinations were, and they were not many, but the common combinations were big C with JKA and big E with DIA, Diego. We then looked at survival using Kaplan-Meier curves. The Kaplan-Meier curves demonstrated that younger patients do better with liver transplantation, and they have a better survival. That is not surprising, but that is to say that patients who were older still had great outcomes. And you could see at the median survival for both groups, if they're less than 65 is 17 years, if they're greater than 65, they're 10 years. And because generally older patients have comorbidities such as cardiovascular comorbidities or infectious comorbidities. Then we looked at sex, and we saw that female patients did better, significantly better than male patients. The reason for this, and again, you could see our significance here. It's very close to being not significant, but we did get significance. And I will touch upon this, why we think this may be the case, and this is still an active area of investigation. It could be that, and I'll touch upon this in the past few slides. But again, the median survival for both cohorts was quite good. Males was almost 15 years, and females was 17 years, so still quite good. We looked at red blood cell allo antibodies association with survival, again using Kaplan-Meier analysis, and we sadly because it made it harder to publish, but this is great news for patients and for transfusion medicine doctors and for surgeons and for clinicians. So great news for them, challenging news for us, because we did not, this was like a bummer, because we're like, dang, we were hoping to see a difference because the previous study showed a difference. So this made it harder to publish. But do not fear, this was published. And I'll talk a little bit about that challenge later. But we did not find an association. We showed that patients with or without red blood cell antibodies have great survival at 15 years, almost 15 years if they're red blood cell alloantibody positive, and 14 years if they're negative. We also then proceeded, because we had enough of these cases, and we were lucky in our cohort to have enough of these cases, to see the difference between one alloantibody, one red cell alloantibody versus two red cell alloantibodies. And we found that we began approaching significance. The curves were separating, but we possibly were not powered enough to detect significance. So both patients with one or more antibodies, they have great median survival at almost 15 years, or 13 if it's two or more. And again, this just taking a step back, these are amazing survivals. 15 years, a median survival with a liver transplant. That means a patient and their family can have 15 years more of time spent with that person. Like, that's incredible. That's incredible. They can help raise their kiddos. They can watch their kids grow up and go to like high school, college, and so on and so on. So very, very profound medical science has allowed this to happen. So very, very great for patient care and patient outcomes. So we looked at the reported cause of deaths in patients with liver transplantation, and unsurprisingly, this has been reported before in other studies, and we revalidated those results. We found that infection was the leading cause of death for patients, And then after that, if primary malignancy, solid malignancy, and then recurrent disease malignancy for those patients. And then cardiovascular issues and pulmonary insufficiency, respiratory failure. We also had a few COVID cases in our cohort as a cause of death because some of the data was collected during the COVID pandemic. And we also had that there was a total of you could see the unknown. There's about 436 patient deaths among this cohort occurred during the study, and they were unknown because they occurred outside of like the patient either died at home or long-term care facility, or they transferred to a different hospital. Okay, and I zoomed in on this part. Thank you. So we also had a question of, because Dr. Ramsey raised an incredible point. He was like, great, we're seeing a positive trend, but can we look at survival in 5-year periods to see how survival changed? And you could see that due to, again, education and due to liver transplant outcomes and better transfusion guidelines and better surgical technique, 5-year periods of liver transplant outcomes improved significantly over time. You can see the green line right here. That is the most recent 5-year interval in the study. And it has improved over time. So the conclusion of our paper is red blood cell allo antibodies are not associated with decreased survival. Alloimmunization prevalence in our cohort was 6.5. The 3 most common antibodies that we saw were big E, JKA, and big K. 30% of patients had more than one red blood cell alloantibody. Here's the fun, well, the challenging part of our study, because this was challenging to explain in the discussion. All-cause mortality was higher in men and in patients greater than 65. Sex disparities have been previously reported in females versus male patients, with females having better outcomes than male patients. And we don't know why this is, but we thought that based on what others have reported, that it could be that female patients have non-metabolic and non-viral diseases and lower incidence of pre-transplant cardiovascular conditions because that can affect liver transplant outcomes. And then also, interestingly, younger females were found to have less graft fibrosis and better outcomes, and it's believed to be maybe secondary to estrogen effect, but this is still an area of active investigation, and the answers are not clear. But this is an interesting fact because there are studies that are looking at how to reduce liver fibrosis, so maybe using an estrogen analog can help. And again, the 3 top causes of death that is also reported in the literature is infection, primary malignancy, solid tumors, and recurrent malignancy. So let's look at Boyd's limitations and our limitations. We had a larger cohort, so that's good for us, yay. But we didn't really mention hemolytic transfusion reactions. Boyd didn't do it, so we're not going to do it, but also we are going to focus on that aspect in our future studies. This is crazy. We did not do a multivariate analysis because specifically for our study, we focused only, and we wanted to focus only, and we wrote up our protocol to focus only on red blood cell antibody and survival. We had a very clear-cut methods for this part. So we did not do a multivariate analysis. We looked at associations. And again, that's kind of where we are. So here we are, we crossed the finish line. This paper was published. A little bit backstory on this paper. This paper was published on the 4th or the 5th submission. We went to the original journal, which published the 2007 Boyd paper, to try to publish this paper. That journal was not interested. And then we went to different surgical journals, transplantation journals. Those journals were also not interested. We even had a leading transplant surgeon on our paper, and it was just surprising to me that surgical transplant journals are not interested in what seems to be great news for them. So it made us sad. But we kept trying to publish it, and I think on the fifth submission, we published it in a really well-esteemed pathology journal who appreciated the significance of this paper. And this paper was significant because we had people reach out to us, pathologists, transfusion medicine doctors, after this was published saying, hey, I read this paper, thanks. And they had a couple more follow-up questions. So the moral of the story is here, don't give up. Keep trying to publish a paper and do not give up because it will get published. And yeah, great. So this is us at the Houston AABB. You could see we visited this conference. It was awesome. And we had a great time. Julian will definitely run this race in the future, the 5K at AABB for fundraising. He didn't run it this time, but definitely will run it in the future. The next question that Dr. Ramsey asked is, great, we published this, this is good, this is cool, very cool, very cool. But what about patients who had difficult antibodies? And you might be asking, what are difficult antibodies? Because that's what I asked. I didn't know what difficult antibodies were. He defined difficult antibodies or difficult red cell antibodies as a criteria that it's greater than 3 antibodies or less than 25% of random donors are compatible. And 1 to 4% of all liver transplant meet this criteria. And again, very, very niche specific cohort, but a challenging cohort. And we, again, had enough, we were well positioned to go into this direction and study this cohort. The typical management, and this is again depends on institution-specific protocols, when sufficient antigen negative units may not be available, we could start with at least 10 units that are antigen matched, but when more compatible units are available, we could use those before switching to antigen positive units or antigen untested units and end with antigen negative units. And again, these cases are poorly characterized and more information is needed. So we just said, why not? We could look at this study. We went ahead and we had a second paper that we published that, let's just do this, that looked at characterizing the challenges of managing difficult red blood cell antibodies in liver transplant recipients. On this paper, I had Dr. Margaret Fink. She was, at this time, an amazing medical student who was happy to work on this paper and volunteered to help. So it was awesome working with her. This was supervised by Dr. Glam Ramsey. Dr. Sean Stowell also contributed. He's amazing. And again, Dr. Guang Yu Yang was on this paper as a lead PI. Fantastic mentor. And the liver transplant recipients, we found that with difficult red blood cell antibodies increased the risk of adverse transfusion events. And that is what the hypothesis that we had going into the study. And we already defined difficult antibodies. Here is our cohort. You can see we're talking about our demographics and clinical features. The median age of the cohort was similar. We had 50 difficult antibodies and 39 non-difficult antibody patients, NDAs, and 50 DAs. So DAs, difficult red blood cell antibodies, and DAs, non-difficult red cell antibody. The cohorts were similar. The sex between the cohorts, male and female, and pregnancy history was also similar. MELD was similar. We found that there is the probability of getting an antigen negative donor, unsurprisingly, with difficult antibodies was lower because they're harder to match and it's challenging. These patients received less units median in intra-op. They could have received more units later, but intra-op they received less. And then the non-difficult cohort, which is right over here, and let's go here. And over here we had patients with multiple red blood cell antibodies. In the difficult group, we had 56 patients who had just 1 and 34 in NDA, and then the greater than 1 we had 24, and the non-difficult we had 5. So you can see that there's a difference, that we had 22 patients in this cohort who had more than 1 antibody. The median survival in years, again, like we previously published on, and this is not surprising to us, was not significantly different. And we compared the two, but you can kind of see that it is a little bit different at 15 years and 10 years. There is a difference, but that difference is not significant. We used initially a histogram to look at what antibodies were most frequently identified in the difficult antibody cohort. We found these antibodies to be anti-JKA and anti-big M, and in this cohort, big E and big K were less common. You could see that shown right over here. And again, big E, this is just reiterating the same fact. Big E was not as commonly present in the difficult antibody cohort. JK, the kid group, was more commonly identified, and the big M. And this is just to reiterate that even though these antibodies, like the reviewers for this paper, they raised a comment. They're saying that, hey, you kind of defined this criteria, and you're just showing the facts that are supporting that criteria, and they were partially right. And then that was a great comment on their part, that yes, we are defining a criteria, and we're just demonstrating that yes, based on our definition of our criteria, we are catching the cases that we set out to capture in the study. We looked at the survival difference, and unsurprisingly, there's no survival difference between difficult anti and the non-difficult antibody cohort. Again, this is like great news for patients, like hooray, challenging news for publishing this paper, because there was some minor issues publishing this paper again, but we published it. And when we looked at the interesting part, we looked at adverse transfusion events that occurred in our cohort. Keep in mind, we have to zoom out again. We had a cohort of almost 1,400 patients. We only found 4 adverse transfusion events, and they occurred in the difficult antibody group. So we anticipated them to be here. And only 2 of them were delayed hemolytic transfusion reactions. 2 were delayed serologic transfusion reactions. And this is just to reiterate that we expected this to be here, and these reactions are so low. And despite the incidence of adverse transfusion events, it was still very, very low. We could talk about them very, very briefly, and because they are interesting. We could just talk about the delayed hemolytic transfusion reactions. So patient number 3, he did not get incompatible blood, and but the outcome was post-liver transplant. They had an anti-D, big C, and a JKA alloimmunization, and this was found post-transplant. So there's a possibility that this patient had negative antibodies. This patient did not have antibodies prior to the transplant, but then received antigen-negative units antigen positive units during the transplant, formed the antibodies, and then they were getting transfusion support possibly after. I don't know the exact specific details because this case was quite a long time ago, and they received some minor antigen blood group incompatible units, which went on to be undergoing delayed hemolytic transfusion reactions. So these antibodies were found 1 month after transplant. The other case is more interesting. And we don't have a great explanation for this case. This patient on their initial screen had a JKA antibody and a little c. They did receive incompatible blood during the liver transplant because I believe this patient, I have to double check my notes, but they got like 15 or more units. So this was a complicated case for various reasons. Their outcome was that they developed what looked like a possible anti-big S, and it was reacting at 37 IgG. And we're not quite, we typed the units after, to antigen type them and see what the patient received. I believe 2 of those units were big S antigen positive, but that still didn't fully explain the picture. There was also a possibility that this patient had a lymphocyte passenger syndrome, and that can occur when the liver gets when the liver B cells in the liver that are transferred with the donor liver into the recipient, they see the recipient's blood groups as foreign, and they make antibodies against the recipient blood group. And in the literature, passenger lymphocyte syndrome, when it occurs due to a liver transplant, the hemolysis, the late hemolytic transfusion reaction, usually resolves within a month. Those B cell clones apparently survive about 30 days. So this was an interesting case, but despite all of this, the adverse transfusion events in liver transplant patients in our cohort was very, very low. So we had the data. So we went and tried to look at liver pathologies that could be associated with the red blood cell antibodies. And to do this, we did not have enough cases. We were not powered sufficiently to do this. You could look at this and see some trends, maybe, but we were not powered enough to do a great analysis of this. Like, for example, some interesting things did pop up, like there were more anti-big M antibodies, big K antibodies in patients who were hepatitis C virus positive for that, more KID A in patients who were positive for NASH disease on their on their Txplnt liver pathology. And but again, it's hard to say like if this is, because our study is just an association study, so it's hard to make any conclusions, but it is very interesting, and this was a fun figure. We also looked at recurrent disease, post-transplant complications, and post-transplant malignancies, and we tried to see if red blood cell allo antibodies are associated with them, and we found, sadly, good for the patient, bad for publishing, is that red blood cell antibodies are not associated with recurrent disease, post-transplant complication, and post-transplant malignancy. And there was a statistically significant association with recurrent disease with JKB because we saw more of them in the recurrent disease cohort. But it's challenging to really say what that really means mechanistically. But it's a topic that is something that's very interesting to me. And we also looked at rejection and liver transplant and antibodies, and there were some really weak associations there, but the reviewers had great comments about it, and they said that, hey, you're just looking at this in retrospective. Like, you could, like, if you publish this, like what does it even mean? And we agreed with them those results will convert to supplementary figures, so they should be available with the supplementary data for this paper. All data was published for this manuscript. So the conclusions here, as you could see, red blood cell antibodies are not associated with survival, and greater younger patients and female sex is associated with improved survival. The difficult antibody group contains increased JKA antibodies and anti-M. They have an increased transfusion adverse events, but the overall number is still quite low. There's a decreased probability of finding antigen-negative red cell units, which makes sense because they're more challenging to find, and they may not be available at the time that this transplant occurs. So that makes sense. And this patient group received less units during the transplantation, but they could have received more units later when those units arrived from the blood center, like Red Cross or Versity or your favorite blood center. And here we are again. We finished it. We crossed the finish line. We were able to publish this paper, and it was fantastic working with our awesome team. You could see that, again, the story here is we tried publishing this in 2 other journals. They rejected it. They gave great comments though, so the comments were really appreciated. and they were really great comments from the reviewers. So they were integrated to make the version better, and then we published this paper again. It was a great experience. So future research directions, and does this trend hold in other solid organ recipients? What about stem cell transplant patients? And that there's been some literature here about it, and I kind of looked into this direction a little bit with the cohort that we had at DIDMC, so I'm happy to talk about that. Kidney, I would love to look at this in the kidney transplant cohort. So that would be really fun to see what kind of associations we can find there, what could it mean, if anything, and hopefully be more good news. And other aspects that are interesting to me, maybe could be a research direction in the future, in the 5 to 10 years, is looking at red blood cell antigens in the gastrointestinal tract, or disease biomarkers, disease associations. This is a niche area of transfusion medicine, crossover, infectious disease, crossover, GI pathology, crossover, biomarker study, but there's a lot here, and there's so much fun information that can possibly be looked at, maybe for drug discovery, maybe for biomarker reporting. Like there's a few papers linking SID antigen with colon cancer, and I read those papers, they're okay, but so maybe a larger study can be warranted to study this better. And then Lewis and H. pylori, celiac disease, IBD, there's associations there. So it's very interesting to look at this direction in a place that has the resources and is well powered to do this, and has the opportunities and the people. And I want to say a massive thank you to my mentors, my colleagues, my collaborators for these projects. Dr. Glenn Ramsey, Dr. Guangyu Yang, Sean Stowell, Dr. Carrie O'Brien, Dr. Richard Haspel, Margaret Fink, and Alcino Perez Gama. They were significant, pivotal people who helped during challenging times of these projects, because I'm not gonna sugarcoat it. Some of this stuff was hard to publish, and they were amazing mentors who helped to move this to the finish line. Also, the Northwestern Memorial Hospital Blood Bank, where most of the all of this work was done. So huge shout out to them, and to Julian right there, because he is playing with the AABB antibody that I got for him as a toy from the AABB conference. Is he going to be a future blood banker or immunologist? I don't know. Maybe. We'll see if he's into that area of study. So thank you so much for listening. This was thank you so much for listening. This was a practice presentation, and happy to take any questions. Thank you.